Most of you know that I'm Dr. Laura Lee Hall, the COO of the National Minority Quality Forum's newest organization, Sustainable Healthy Communities. And I'm delighted to be introducing a panel of now friends, but experts that I admire deeply. Let me quickly tell you who they are. First, you're going to hear from the inestimable, I risk saying that wrong because Dr. Fryhofer is just an amazing primary care physician, healthcare leader, immunization advocate, and she's really going to share with you what vaccines we all should be getting, and she's going to do it in a way that you'll never forget. You'll be dancing in your seats. Following her is someone who is equally outstanding, Dr. Soppet at the end. He is also a general internist who turned his innovative thinking and entrepreneurial spirit into doing great care for his patients. And, you know, he made it work. And your docs and you can make it work, and he's going to share some tips about doing that. Finally, there's probably no one in Washington, D.C. who knows more about the vaccine policy scene than Phyllis Arthur here. So she's going to give us a little update on kind of what helps and what's not helping. And I think we'll all go out of here ready to get our shots, give our shots, and maybe give some policymakers a shot. Yeah. Thank you, everyone.
That would be the goal.
Okay, I'm the first speaker, and my job is to talk about vaccine recommendations, practice, and policy. So I'm going to talk about the vaccines that we need to be thinking about for our patients. And let me get the slide clicker and see if this works here. So each year, thousands of adults suffer diseases vaccines can prevent. Many of them die. They don't have to. ACIP, which is the Advisory Committee on Immunization Practices, recommends 13, a lucky number in this context, at least 13 vaccines for adults. ACIP, the Advisory Committee on Immunization Practices, consists of 15 voting members that are appointed by the Department of Health and Human Services Secretary. There are also 30 non-voting liaisons, and I'm one of those liaisons at ACIP. Since October of 2010, all ACIP recommendations have been evidence-based using the GRADE formula. And ACIP recommendations come in two different categories. Category A recommendation is for all persons in an age or risk factor-based group. Category B recommendations are for individual clinical decision-making. And please note that ACIP recommendations do not always correspond with FDA licensing parameters. Also, the ACIP recommendations have coverage clout under the Affordable Care Act. Under ACA, all new health plans have to cover all ACIP Category A and B recommendations without cost sharing 1 year after the recommendation is made. However, this does not apply to Medicare. So every year, ACIP summarizes the immunizations recommended for adults in one very nice way. They come up with the adult schedule, and for the 10th year in a row, this has been published in the Annals of Internal Medicine. This document organizes vaccines by age group and by medical condition. And it's very important to read the footnotes. Although those graphics look very clean and streamlined, there's so many details in the footnotes that you really need to know about who to give which vaccine, how many doses, and the interval. So those footnotes are packed full of important information. Every vaccine has a vaccine information sheet that's available on the ACIP website. And what I do is I have a book in each exam room that has all these vaccine information sheets. I'll introduce the vaccine, give the patient the vaccine information sheet, walk out, do something else, come back, and then answer any questions. And these are so excellent that usually, they've answered most of the questions that patients do have. All right, let's get started with some of these vaccines. Let's start with flu. Everyone 6 months and older needs flu vaccination every year. That hasn't changed, but the how has changed. For this season, the 2016-2017 season, the nasal flu vaccine is out because studies show it just was not effective. However, there are plenty of other choices to choose from. The inactivated flu shot, IIV, the cell-cultured version that's almost egg-free, the totally egg-free recombinant influenza vaccine. And for those aged 65 and older, there's the high-dose IIV and also the new adjuvanted IIV. Remember that babies under 6 months old are too young to get vaccinated. These little ones are most at risk and are more likely to be hospitalized or die if they get flu. So family members and caregivers of all babies need to make sure that they get vaccinated against flu. So speaking about babies, let's move on to pertussis, aka whooping cough. Over the last 10 years, there's been a surge in whooping cough deaths in infants. And so what we try to do now is cocoon these little babies in a circle of familial protection. What we found is that household members are to blame for more than 80% of all transmission. So unvaccinated dads need a one-time Tdap booster, grandparents need a one-time Tdap booster, pregnant women need a Tdap booster in each and every pregnancy in the late third trimester between 27 and 36 weeks. Now understand that multiple Tdap boosters is an off-label use. Let's now move on to cancer vaccines. And let's start with HPV. And here's the picture of that pesky little virus. All right. If you don't want to look at these pictures, just close your eyes. I'll tell you when it's over, because this is what we're trying to prevent. Invasive cervical cancer, anal cancer, genital warts, more genital warts, and another warning, this one is really kind of a yucky picture, penile cancer. So HPV-related cancers affect men and women, in females and in males. Anal cancer and oropharyngeal cancers also affect males and females. So HPV-related cancers have a profound impact on our society. Now, what's new about HPV vaccination? Well, as of late 2016, there's only one HPV vaccination now available in the United States, and that's the 9-valent vaccine. And there are also fewer doses for some. For patients that start vaccination before age 15, they only require 2 doses, but these doses have to be spaced out at least 5, preferably more than 6 months apart. If you start later than age 15, you still need the 3 doses. So a reminder, we routinely start vaccinating at age 11 or 12. You can start as early as age 9. All females through age 26 need to be vaccinated, all males through age 21, and through age 26 for immunocompromised males, males with HIV, and males who have sex with other males. Another cancer vaccine, hepatitis B vaccine. Each year, there are 800,000 to almost 1.4 million people that suffer from it, and this chronic infection can lead to liver cancer. Who needs hepatitis B vaccination? Well, certainly all healthcare workers and all public safety workers, all diabetics under 60, over 60 at physician's discretion. If you've had one or more sex partners within the last 6 months, you need to have hepatitis B vaccination. MSM, IV drug users also need it, as well as those with chronic liver conditions. And for the new schedule, the specifics of who chronic liver conditions applies to was specified, and that includes patients with Hep C, cirrhosis, alcoholic liver disease, autoimmune hepatitis, fatty liver disease. Now, if you think about the risk factors for fatty liver disease, is obesity, there might be a lot of patients in your practice that now need Hep B vaccination. And also anyone with an ALT or an AST more than 2 times normal. So in the past, I think we might have thought about hepatitis A as just a travel vaccine, but there are other people that also need to have Hep A vaccination. Patients with chronic liver disease, MSM, IV and non-IV drug users, anyone with lab exposure to Hep A, and close contacts of international adoptees from countries with endemic Hep A. The next vaccine we'll talk about, there's a hint. This is quality of life, and this is shingles. If you've had chickenpox, you're at risk for shingles, and more than 90% of all adults in the United States have been infected with the varicella zoster virus. There are about 1 million cases of shingles every year. Lifetime risk, 30%, and the risk increases with age, starting at age 50. The key symptom of shingles is pain. And for some people, that pain can go on for months, even years, if they have post-herpetic neuralgia or PHN. There's a vaccine to prevent this. The shingles prevention study showed us that the only shingles vaccine currently available, the live attenuated virus vaccine, Zostavax, reduced the incidence of shingles by 51% and reduced the incidence of PHN by 66.5%. ACIP says start vaccinating at age 60. Again, this is a live attenuated virus vaccine. It should not be given to patients with immune system problems. It should not be given to anyone who's pregnant. But I mean, really, how many pregnant 60-year-olds do we have walking around? But it also should not be given to anyone who's allergic to vaccine components, and it's also contraindicated in patients that are on high-dose steroids. Just a heads up, there's a new investigational vaccine under study. You might have seen this study in the New England Journal of Medicine. This new vaccine that's not yet available had efficacy of 97%. So just keep your eyes peeled, and hopefully this vaccine will become available sometime within the next year. This is my grandmother, Minnie Wade Youngblood. She died 2 years later at age 74 of pneumococcal pneumonia. So strep pneumoniae, aka the pneumococcus, kills about 4,000 people in the US each year, mostly adults, and it's a leading cause of serious illness. There are 2 vaccines currently available, the Pneumovax, the pneumococcal polysaccharide vaccine, PPSV23, and the pneumococcal conjugate vaccine, PCV13, brand name Prevnar. Now, what we know is the risk of pneumococcal disease in patients that are immunocompromised is more than twice that of those without high-risk conditions. We also know that the risk of invasive disease in older adults is about 10 times that in younger adults. And these are the 2 reasons why ACIP recommends routine PCV vaccination for these 2 groups of patients. The Capita study showed us that the PCV13 was effective, 75% effective in preventing vaccine-type invasive pneumococcal disease, and 45% effective in preventing vaccine-type non-bacteremic pneumonia. Okay, so there are 2 shots, but understand that this is the most complicated ACIP vaccination recommendation. I'm going to review a few ground rules and also refer you to the footnotes for all the details. PCV13 and PPSV23 should not be given at the same time, and the interval between the 2 vaccines matters. If patients need both, it's best to give the PCV13 first, but only a single dose of PCV13 is recommended for adults. Only 1 PPSV23 dose needs to be given at or after age 65. So the pneumococcal vaccination recommendations are based on age and medical conditions. It's all in the footnotes. Here's a summary slide. But I just encourage you, when you have a patient, just to try to find that person in the footnotes and do your best. It's a complicated recommendation. Okay, coverage. These are not inexpensive vaccines. Now, fortunately, Medicare will cover 2 different pneumococcal vaccines, but here's a twist. For immunocompromised patients, remember we said that we give one and then give another. For immunocompromised patients, that interval is 8 weeks. However, Medicare will only cover a second pneumococcal vaccine 11 months later. So, for these high-risk patients, there is a Medicare coverage gap. And you have to decide between doing what's best for the patient, which would be vaccinating for that 8-week interval, but patient may not be covered by insurance. In fact, Medicare will not pay for it, or waiting 11 months and getting Medicare coverage for that vaccination. Next, meningococcal disease. This is one of the most devastating diseases that I can think of, and it's certainly, as a parent, when I sent my kids off to college, one that I certainly worried about. There are 5 main serogroups of Neisseria meningitidis, but types B, C, and Y cause the major disease in the United States. And you might recall there was a meningococcal B outbreak at Princeton a few years ago. There was a meningococcal B outbreak at the University of California, Santa Barbara a few years ago. Now, when those outbreaks occurred, there was not a meningococcal B vaccine that was FDA approved. They were able to get a vaccine for investigational use to try. But now, fortunately, we do have a MenB vaccine. So a reminder for young adults, something really important to remind the parents of kids going off to college. First-year college students age 21 and younger who live in residence halls should receive 1 dose of the MenACWY if they have not received one at age 16 or older. And also the MenB series may be administered to those aged 16 to 23. And these 2 different vaccines may be given at the same time, but at different anatomical sites. So in summary, there are 2 MenACWY vaccines available. There are also 2 different types of MenB vaccines available. You might note the different dosing. Whatever MenB vaccine you start with, you need to finish that series with that same vaccine. Now, when the MenB vaccines were FDA approved, FDA only approved them for those aged 10 to 25. And this is an example in which the ACIP looked at the data and expanded that age indication to anyone aged 10 and older at increased risk of meningococcal B infection. And there's also a growing body of evidence showing that patients with HIV are more prone to get meningococcal infection. So the new schedule actually included a recommendation for the MenACWY for all patients with HIV. And then they would also need revaccination every 5 years. MenB vaccination for those with HIV is not currently recommended. So again, here are the meningococcal vaccination indication summary. This all came from those footnotes, so lots of information in the footnotes. So why is Snow White crying? She's heard there was a measles outbreak at Disney World. And if one person has measles, 90% of those people around them will also become infected. And we even had a measles death a few years ago. So why are these characters from the Jungle Book mad? It's because there was a mumps outbreak in the National Hockey League. So remember, there is a vaccine for this, the MMR vaccine. Adults born before 1957 are generally considered immune unless you're pregnant or a healthcare worker. This is a live virus vaccine, so it should not be given to women while they're pregnant. It should not be given to anyone who's immunodeficient or patients with a low CD4 count. Again, check the footnotes to see who needs what, when, and how many doses. And last but not least, Hib, the Haemophilus influenza type B vaccine. If you don't have a spleen, you need a dose. If you're planning to have your spleen removed, you also need a dose. If you've had a stem cell transplant, you need 3 doses. The Hib vaccine is not routinely recommended for patients with HIV because their risk of Hib infection is low. So I've gone over these lucky 13, but the reality is adult vaccination rates are abysmal. And this information, the coverage rate is summarized on this slide. But what is not shown on this slide is how the ethnic disparities that occur with vaccine coverage. So if you look at flu, for 2015 from the NHIS data, 41.7% of people were vaccinated, of adults. But if you look at whites, it was 44%, African Americans 36%, Hispanics 34%. For Tdap coverage, 23.1%. But for African Americans, the coverage number was 15%. For Hispanics, 14%. For the shingles vaccine, the zoster vaccine, 30.6% coverage overall. African Americans, 13%. Hispanics, 16%. For pneumococcal vaccination, for the high risk 19 through age 64, 23% were vaccinated, but for Hispanics, 19%. For patients over 65, 63% were vaccinated. For African Americans, 50%, Hispanics, 41%. So we have some disparities that all of us need to be concerned about. And throughout all the different vaccinations, there was higher coverage for whites than for most other groups. And African Americans and Hispanics were at the lower end of coverage as compared to whites. And this is the source of that data. This will be posted on the website. So I encourage you to take a look at that, talk to your coworkers, and we really need to level this playing field. Another thing that's concerning, especially with what's going on in Washington and the Affordable Care Act, is the effect of having health insurance on vaccination rates. And in the Annals study, it actually demonstrated numbers that showed that adults with health insurance are 2 to 5 times more likely to be appropriately vaccinated. These were spelled out for each of the different vaccines I just mentioned. So you've heard about the Lucky 13. I hope each of you will think about this information as you go home and to your prospective states and try to encourage adult vaccination. But if we think about the amount of time that we have with patients, there's a lot that goes on in that visit. And the reality is, in real time for a vaccination, it happens one patient at a time. So in order to get it all done, we have to be motivated. And I now want to share with you a video presentation that the Georgia Physicians Leadership Academy put together to help physicians and other providers in Georgia get motivated to vaccinate. Every year, thousands of adults suffer diseases vaccines can prevent. Many of them die. Too many. They don't have to. ACIP, the Advisory Committee on Immunization Practices, recommends 13, a lucky number in this context, at least 13 vaccines for adults. The real bad luck? Vaccination rates for adults are abysmal. That has to change. This is how.
Your mission, should you decide to accept it, is to raise adult immunization rates. If you succeed, you will save many lives.
If you fail, MAG will disavow any knowledge of you or this mission. Just kidding, right, Duchess?
Our country is depending on you. Will you accept this challenge?
Of course we do.
We
are the vaccinators.
Go out into the galaxy, young Jedi, and fight the infections that ravage our innocent populations with prevention, with vaccination. And may the Force be with you.
Our goal is move the needle.
Improve adult vaccination rates.
Save lives.
I
like to move it, move it. I like to move it, move it. I like to move it, move it. You like to move it. I like to move it, move it. I like to move it, move it. I like to move it, move it. You like to move it. I like to move it, move it. I like to move it, move it. I like to move it, move it. You like to move it.
Our first target, influenza.
Influenza kills as many as 49,000 adults a year, depending on the flu season severity. Everyone 6 months and older needs flu vaccination every year, pregnant moms included. Their vaccinations protect their babies in their first 6 months of life when they're too young to be vaccinated. Babies born to vaccinated mothers are 64% less likely to get sick. Everybody 6 months and older needs a flu vaccination every year. No excuses. How many people get them? Only 43% of adults. They and we need to do something about that.
I'm Matt, Dr. Matt Aston. Some call me Mighty Matt. I'm an emergency room physician. A good one. I know people don't much like needles, but they are good things. They help vaccinate you. One of the best motivators for getting patients vaccinated is a recommendation from their physician. That's me. One reason people come see me is for good advice. Well, here it is. Get vaccinated. Tell them Dr. Matt sent you. Oh, and if you're a doctor, give them.
The name is Scott. Al Scott. Dr. Al Scott. I'm an OBGYN. Pertussis, whooping cough, is what I'm after. It kills our babies. More than 80% of the time, infection sources are household members whose childhood vaccinations have worn off. The antidote? Tdap vaccination. The Tdap booster targets tetanus, diphtheria, and pertussis, and it's for everyone. Adolescents, adults, and seniors.
Every expecting mother needs a Tdap booster during every pregnancy and the third trimester, even if she's been previously vaccinated. Those antibodies are passed along, protecting the baby during the first months of its life. Everybody who's going to be around a baby needs a booster, and so does everybody else. Can't stop that. Can't stop that. Can't stop that. HPV, the human papillomavirus, causes cancer. An HPV vaccine is available and effective and can prevent cervical and other genital cancers. It works best given before exposure to the virus. The HPV vaccine series is recommended for all boys and girls at age 11 or 12. It can be given as early as age 9.
Catch-up HPV vaccination is recommended for all females through age 26, for all males through age 21, and through age 26 for immunocompromised males, and for men who have sex with other men.
A kiss on the hand may be quite continental, but vaccines are a girl's best friend. You may think a shot isn't something you're craving, but it could just be the thing that saves you or me. It's good luck to come, get stuck, and on this you can surely depend. For Hep A and B, Tdap, and HPV, vaccines are a girl's best. Vaccines are a guy's best. Vaccines everyone's best friend.
These vaccines are expensive, but I have my sources. I can tell you how to get a good deal. We've got information about vaccine purchasing groups that can save you money.
Under ACA, the Affordable Care Act, all new insurance plans have to cover all Category A and B ACIP vaccination recommendations. This means first dollar coverage with no cost sharing. That's good news for your patients and their pocketbooks.
But what if you don't have time or the staff to give immunizations in your office? Your patients still need them. Your neighborhood pharmacist can help.
They're open after office hours and on weekends, making it easier for patients to get the vaccinations you recommend.
We're glad to have a new partner in the fight against vaccine-preventable diseases.
It's a beautiful day in this neighborhood. Beautiful day for a neighbor. Would you be mine? Could you be mine? It's a neighborly day in this beauty wood. Neighborly day for a beauty. Would you be mine? Could you be mine? Please won't you be my neighbor?
To help convince you and ease you into the mood to vaccinate, we've worked to make it easy. We've put together downloadable patient education videos on flu, Tdap, and HPV vaccination.
There's a section on the nuts and bolts of vaccine financing and how to get paid for the work you do.
We also have a source of immunization wallet cards for your patients.
And don't forget about grits.
Did you say grits?
Not those kinds of grits. We're talking about grits. Georgia's immunization registry, designed to collect and maintain accurate, complete, and current vaccination records for all Georgia residents.
Are you up to date on your vaccinations?
Good habits begin at home, the medical home. So set a good example for your patients. And remember,
We are the vaccinators.
Please join us.
I'm Dr. Quentin Perkle, Chairman of the Board of the Medical Association of Atlanta. Please vaccinate. It's important.
Hi, I'm Marilee Gober, the President of the Medical Association of Georgia Alliance and also an RN. I believe in vaccinations. Please get vaccinated.
Hello, I'm Dr. Royden Daniels. I'm a radiologist and a board member with the Cobb County Public Health. I support getting vaccinated.
My name is Gabriel Pajares. I'm a medical student at the Medical College of Georgia. Please get vaccinated.
Hello, my name is Michael Wynn. I'm your neighborhood pharmacist. Please get vaccinated.
I'm Dr. Don Gilner. My practice is allergy, asthma, and immunology. Immunology, very important to be vaccinated. Please get vaccinated.
Hola a todos, soy Mayra Farías. Trabajo para la doctora Fryhofer en su práctica privada. Por favor, todos tienen que vacunarse. Gracias. Hello everybody, I'm Mayra Farías. I work with Dr. Fryhofer at the private office. Please everybody get vaccinated.
So I have to catch a flight back home because I am a practicing doctor and I have actually a patient coming in this afternoon. So I really am honored to have been here. And if any of you want to show this video to your staff or at a meeting, you can download it from at the Medical Association of Atlanta website. And please do share it. But it's been a fun way for us to promote vaccination in the state of Georgia.
Laura Lee, I know we got started a little bit late today. I put together about 15 minutes. I can shorten that. People look like they're getting hungry.
Let's go for it.
Okay. Well, coincidences intrigue me. They often lead us to places, both figuratively and intellectually, where we never expected to go. So I look for them. I grew up in a gambling town. And I've long had an interest in gambling and gaming and the strategies of gamblers. I didn't know until I was an adult that I was actually a gambler myself, and I'll explain that to you. 7 years ago, the ACA kind of fanned my interest in immunizations, and I expected and braced myself for this tsunami, this great wave of immunizations that were going to occur in adults as a result of the first dollar coverage and the increased insurance coverage for our patients. So in mathematical terms, a fair game is considered one in which the probability adjusted weight of each outcome adds up to 0. And you can think of your coin tossing game. So if you have $1 and you bet $1 on heads and you win, you get $1, and if you lose, you get $1. So 1/2 a percentage, 50-50 chance of getting heads times $1 is 50 cents, minus 50% chance of losing $1 is 50 cents. 50 minus 50 is 0. So that's a fair game. Let's see. Good. And I'm glad I'm between Phyllis and Sandy. Sandy had told us about the recommendations. I'm going to talk here today about the practice of medicine, and policy is what Phyllis is going to talk about. And I've often thought that practice is the bridge between policy and recommendations. So a few years ago, I started on kind of a quixotic journey to try to improve immunizations in patients, right about 2010 when the ACA came about. And I was struck by this particular article in the Annals that came out in 2014, and it's a little difficult to read, but I'm just going to show you that basically it shows that in this question it says, it's my responsibility to stock and administer all routinely recommended adult vaccines. 80% of family practitioners and general internists felt that they agreed with that statement or strongly agreed with it. So this particular group felt that this is what they should be doing. The interesting thing is that there was a discrepancy, a discordance between what they were actually doing and what they felt duty-bound to do. And so in this top this is people who are assessing for vaccination status of patients, and most were assessing for pneumococcal, influenza, Tdap, and tetanus diphtheria, but not for the rest. Less than 50% of physicians were assessing at every visit for immunization status, and even fewer were actually giving it down here at the bottom. Again, they were concentrating on those 4 vaccines at the top. So I wondered, what gives? You know, what's happening here? What's causing physicians to behave in this particular way? And what I thought was that physicians probably didn't understand what was happening in the financial aspects of this. And so I started to explain to them and found out that many already knew that you receive 2 payments for each administered vaccine. You received a payment here for the vaccine itself, and then you received a payment for the administration fee. But most physicians thought that this was a fair game. They thought that they were getting paid about what they were being charged for the vaccine, and that they got a very small vaccine administration fee about in keeping with what the cost was. But this represents a pre-ACA and actually 2 decades old model. Because as you can see, when I started practice in 1976, all the way up until 2000, we in Alabama received $2 for vaccine administration fees. That wasn't very much money, and even if you adjusted that for inflation, it's only about $4.50 in today's dollars. It wasn't until you see about 2002 that we started to see an increase, and now you see there are vaccine administration fees here. I'll go back, are in the $23 range, and in fact, nationwide, closer to the $25 to $30 range for Medicare and then commercial insurance. So the new model that I thought I would go around the country espousing to people to try to get them to vaccinate in their offices was this one, in which the amount that you were paid for this particular vaccine and administration fee and the vaccine itself was far in advance of what you would get in the cost of administration. So I said, if I can just go around and tell people about this, they will all jump on the bandwagon despite what they have been doing between 2010 and 2013, 2014. So what does an obsessive compulsive internist do? You start in a granular manner and you take one vaccine and you show each of the costs involved. In this particular one for pneumococcal polysaccharide vaccine, I put on the left here the vaccine payment, and on the right the administration fee payment. I even put all the costs in. So the vaccine purchasing cost was $80, 10% for vaccine billing, $8, a little bit for needles and such. So the total cost was this, $88.65. We got paid $89.95 by traditional Medicare, and even if we charge, we made a profit of $1.30 or 1.4% on the vaccine. The administration fee was different. The materials cost was very low. Even if you inflate your nursing cost to $8, which is a very slow nurse giving a shot, and your state GRITS registry or whatever yours is, of $5 to access that, and a 10% administration billing fee, the total cost is still $15.83. You're paid $23.09, and therefore your profit is $7.26 on that. So $7.26 plus $1.30 is $8.56 divided by $80. In the worst possible case scenario, you're making a 10% return on investment, and that's inflating all your costs. You wouldn't believe the anger that this engendered among my physicians I was talking to about this. Disbelief and anger. So what did I do? I said, I'm not giving them enough data. And so I went to this. I put down every possible vaccine and every possible cost. And allowing for all possible costs, you could still see that there was a very good return on investment here. Now, I know you can't see this. It's in your slides. But just trust me, it ranges from 20% for Zostavax up to 207% for IIV3 new influenza vaccine. So I presented this at ACP's national meeting. Again, nothing. Just anger. And I was the messenger. So I knew exactly what had happened, and that was that I had presented too much data. So I went back and I simplified for those who are not obsessively compulsive as I was. And so I just put down every vaccine. That's the average cost you could buy it for. That's what you got paid for the vaccine from Medicare. And I did this for every possible insurer and presented it in, many tables. And the average reimbursement, $20, that's taking out all the costs. And you still made a great profit, didn't you? 20 to 200%. This is fantastic. Now they've got to believe me. Wrong. So I'm trying to figure out what's happening. I'm sure you're confused. This is a paradox. We have a better than fair game. Now, a better than fair game is one in which you flip the coin, and every time you win, every time you flip heads, you get $1.10, and every time you flip tails, you only lose $1. Who wouldn't buy a series of those games? And for a long time, it was thought that any rational person would choose to play a better than fair game as many times as they were allowed to do so. So this paradox confused me, but it wasn't without precedent. So this is the court of St. Petersburg in Russia in the 18th century, and they loved to gamble. And because they loved to gamble, they were all the time trying to figure out mathematical formulas for how to do it better. And they came up with this coin toss game, and it's just a very simple coin toss game. You buy a ticket to play this game, and then you flip the coin, and if tails comes up, you get half of your bet back, and you lose half. But if heads comes up, you get your bet to the first power. So in this particular example, it's $2. If heads comes up on the first, you get $2 to the first power, or $2. Then you flip again. And if you flip again and heads comes up, you get 2 to the second power, and so on and so forth. Every time tails comes up, the game stops, and you get to keep what you have. So the question is, how much would you be willing to pay to play the St. Petersburg game? Well, it turns out that you should be willing to pay anything, and that's because of probability expected value of this game. So on the first flip, you got a half chance of getting heads or tails. Half times, say, a $2 bet is $1. On the second, providing you get a heads on the first shot, if you flip and you get heads the second shot, the chance of doing that is 1 in 4 times $2. Anybody? One-fourth of 4 is $1. So this leads, as you play this game progressively, to an infinite string of $1 payments. Who wouldn't play that game? A better than fair game. Well, Daniel Bernoulli is the one who decided why this paradox didn't work, and it has applicability to what we're talking about today. So he saw that instead of a curve in which you have money on this axis, more money here, less money here, and the money and the happiness that this money would buy you, it is not a straight up 45-degree angle. It is a convex curve in which the more money you have out here, the less that bit of money extra gives you in terms of satisfaction, and down here it means a great deal. So this is a way to look at it a little easier. If you have amount of money B and you add $1 to that, B plus 1, you see that the change in happiness that you can buy from that, because of the shape of this curve, is a large delta. And out here, if you have more money, it's a smaller delta. So that's called the happiness index. The second thing he realized is that the fear of loss gives much more pain than the joy of gain. And that's because he recognized that the inverse curve was not what you, the inverse curve of the happiness index is the misery index. So here's the misery index. And what you see is that you start here with 21,000 rupees. You start here with 20,000 rupees, and if you get another 1,000 rupees, that's the delta in happiness that you get, a very small d. Whereas if you start out with 20,000 and you lose 1,000 to 19,000, look at how much misery or how much loss of happiness you get. So that was the first part of the paradox. The second part of the paradox is this: risk. So if you are paying $2 for a game in which you have a chance of winning $2.10 or losing the $2 in a better than fair game, you're more likely to play that game than if you're playing for $4, in which you still only have a chance of getting 10 cents. Risk is how much you are wagering. So what we found is that these two elements that Bernoulli hit upon a number of years ago are what I was running into in talking with my physicians about their ability to maximize their profits by immunizing in the office. I had done quite well, but I had done that through this mechanism. I had looked at the complexity of the immunizing event in the cascade of risk, which is number 2 there, and I had been controlling for that in my practice by a very complex set of steps. I had been concentrating on the direct costs of immunizing when I was talking with my physician colleagues about that, and people are very smart. They intuit risk. They're not foolish. They are not giving up those dollars without recourse. What they're doing is buying themselves insurance. So sometimes the way that you mitigate risk is you choose not to play the game. And that's, in fact, what has been happening with those physicians who do not choose to immunize in their practices. They are giving up the dollars that they could earn, anywhere from 20 to 207%, by not playing the game. Now, there are a couple elements, and I'm almost finished here. First is, look at the complexity of the rules of payment. If everybody older than 6 months needs a flu shot, why is it that we have to do all these things, jump through all these hoops, to prove to people that we need to give them a flu shot? It's ridiculous. But the cost of doing that does entail risk, and it has real dollar costs. Secondly, there's ethical risk, which we don't really think about. But I can tell you in the real world, having practiced in Selma, Alabama, and other areas where we had a large number of patients who were uninsured in our population, if you take the risk of buying vaccines and putting them in your practice, we as physicians want to be equitable. And if a patient is already in our practice, it's very difficult for us to say to them, no, you can't have it because you can't pay for it, but you can because you can pay for it. So what happens? Everybody eventually gets a vaccine if you can afford to do so. That entails financial risk, but also it entails decisional ethical risk for physicians. We will do almost anything to avoid that conundrum, including paying to have that taken away from us. So when we write a prescription to the pharmacy, what we are doing is paying the pharmacy, in essence, to take that risk away from us. Something we don't really pay attention to, but it's very real. And then all this cascade comes together in a risk of financial and other loss. Going back to number 2, The complexity of the immunizing event is enormous. 13 steps I've identified in my practice. I work to reduce the variation in that every day by limiting the number of people who can be involved in it and having very specific algorithms for how they do this. That helps me to reduce my risk of loss, but it does not eliminate risk of loss. It just controls for variation. 13 factorial is what you're dealing with when you're working with the risk with one person doing that. If you have 2 people doing it, it's 13 factorial times 2. And it goes up with the size of your practice. So what have we been doing to mitigate risk in this area? And this is where the policy part comes in. So I'm going to address this to Phyllis and the rest of you. Of course, I've said I control the steps to reduce variation, and successful immunizers do that in their practice. The ACA has made the game more favorable, a better than fair game, and it's done that by increasing the odds of winning, by increasing the number of insured people, and it's also decreased the odds of losing by decreasing the number of uninsured people. We've seen that the administration fees have gone up over the years, which of course increases the payout, and that makes it a better than fair game. But we have very complex rules, and each of those rules introduces risk. We typically take care of that by insuring against loss, and that may be something that we need to think about, is how we in a public policy arena can insure physicians against loss. We have to reduce the steps necessary to play the game. It costs entirely too much time and effort to be paid for what we're doing through the normal insurance realm. We may need to consider moving this out of insurance completely into a different payment mechanism. Make it simple and reducing the risks that those immunizers are taking on. And lastly, we have to in some way remove the ethical risks for physicians. We've done that with the Vaccines for Children program through HHS, but we have not done that for adults. So with that, I'm going to say that I've said coincidences intrigue me. Today is my father's 92nd birthday. And I am here to see you today because there's a finite chance that an immunization that he received as a poor boy in Chicago, having been bitten by a wild dog, got a series of rabies immunizations for which he paid nothing and could not pay. Someone gave him that shot. So there's a finite probability that I'm here not just to talk to you about immunization, but talk to you because of immunization. So thank you very much.
I've got to ask you to kind of be brief.
Absolutely.
Gary has asked that we kind of wrap it up as we can.
Yeah, I don't know.
And I apologize for that.
That's all right. Well, you can have the slides, right? So those of you who are interested in the policy environment for vaccines, please take a look, because what I tried to do was charge you as people who care about vaccinations and vaccinations in minority populations to look at some of the issues we're having in the policy environment for vaccines so that you could take action in your state or here in DC. So I think we all know vaccines are extremely important. The Vaccines for Children program is actually one of the best successes we've ever had in terms of getting more children immunized, and it's affected the lives and the societal costs for all of us. But actually, and Dr. Fryhofer showed this data, I'm showing it in a different way. This is the healthy people, the data sort of visually of how we're doing on vaccinations for the major adult vaccines. And this is that same data looking at it by minority populations. And these are slides that you can get from the Adult Vaccine Access Coalition. It's actually a group of all of us in DC who care about vaccines and vaccine advocacy, and they've made some great infographics that talk about the information. So when you see these brightly colored things, know that you can get that on the AVAC website. So adult vaccines are more complex, different ages, all these different insurance issues, all the different types of immunizers, the fact that you have more chronic conditions, different kinds of, just all these different issues that are much more complicated than pediatric. Therefore, there's a lot of sort of interesting policy problems that we're trying to solve, looking across this broad way that you can immunize. So very quickly in these slides is a look at the current health policy environment. obviously, you all are extremely aware that we are in a little bit of a flux area in Washington with regard to healthcare policy, reform, repeal, replace, whatever the nickname is of the day. And this week, we could very well see another version of the American Health Care Act, which could change a lot of what I'm telling you. And I try to talk about that as I go through it. So this is the base of where we are today. There are policy issues that need to be fixed even in the base of where we are today. And then, of course, there's the issue that all of it could change if the House and Senate are able to pass any kind of reform. So, you know, ceteris paribus, and yet not. So obviously one of the most important things you heard about already is that one of the ACA wins for vaccination across the lifespan is the first dollar coverage provision. This is Section 2713. It requires all insurance, private insurance types to give first dollar coverage to vaccines if they are recommended by the ACIP. The other thing the ACA did was it created the exchange markets, which you've obviously been hearing about, and the essential health benefits. It's important to note the essential health benefits is a particular issue inside the creation of the exchanges. The top part that gives you pre-existing conditions up to age 26, lifetime caps, and the first dollar coverage for preventive services sit above that. They actually apply to existing plans of all types, and then the essential health benefits, which contains those provisions, actually sits sort of nestled inside. But they are not one and the same. They are part and parcel of each other. And then, of course, you've heard about the individual mandate requiring people to have insurance or pay a fine. If you did your taxes, you had to declare that you were insured or pay something. So obviously, we've got several issues inside the private health insurance. One, in-network providers. Boil it down for you, one of the key things is clarifying all the different types of adult immunizers that should be able to offer an adult their vaccines and make sure that person gets those vaccines with no cost sharing. So it means recognizing broader networks for vaccination that include pharmacists, community providers, et cetera, so that beneficiaries don't get there expecting zero cost sharing and not receive it. These are the kind of subtle access issues we're trying to fix. In immunization registry systems, one of the other key areas that need to be fixed, partly for adults to link those community immunizers to the medical home, because the idea here is not to undo the medical home. It's obviously excellent if people get vaccinated in the medical home. Given what we heard about doctors sometimes immunizing, sometimes not, if people go to the pharmacist, we still want that medical home and that provider to know the person was vaccinated. So a lot of work going on to improve the connectivity between providers and IIS systems. Funding. This is going to be the other knockdown dragout we're going to face over this next year or two. And one of the most important programs that funds immunization infrastructure in the states is the Section 317 immunization funding. If you do one thing this year in your state, please tell your legislators, federal, state, that you want to make sure the immunization infrastructure funding stays robust, because it literally does fund outbreak response, it funds the Vaccines for Children infrastructure, it supports actual bodies that do adult immunization. It does a great deal, it's CDC funding, and it literally is the backbone of our immunization infrastructure in the US. Obviously, Medicaid population, this is probably where we will see the most change. It's had the most discussion. It changed a great deal in ACA. This is where the expansion program sat, and literally it drove this access for what we call childless adults. A new Medicaid population. 32 states, I think I looked this up last night, I think it's the right number, and DC have expanded. Other states are looking at expansion. There's a lot of money sitting on the table from the federal government if you expand, but it's a complicated process. And so this allowed us to have a great many more adults, particularly those with chronic conditions, not 65, not dual eligible, actually able to have medical care and then vaccine access. And inside that, vaccine access is supposed to be with no copays. However, the traditional population still remaining their original Medicaid has to have copays. And we've been trying to eradicate that particular disparity between the traditional population and the expansion population for some time. Medicare has a disparity sitting inside it that we've been trying to fix forever. I mean, long before ACA happened. So as you may know, another AVAC graph, there are 4 sections of Medicare. You know this: A, B, C, and D. A is hospital, B is the medical home, C is the sort of HMO model with everything in it, D is the pharmacy benefit. The vaccines are split. When the bill was passed, flu, pneumonia, and hepatitis B were the only vaccines licensed for elderly. They went into Part D, and then because of the ACA, have 0 cost sharing. Unfortunately, what they did was they literally said everything else empty, and since they statutorily listed 3 vaccines, everything else ends up in Part D. That's the pharmacy benefit. Physicians can't bill Part D, hence also may explain why some doctors aren't doing shingles and things in the office. And so you see this big disparity in how the uptake of the newer vaccines, because you have this really broad set of copays that depend on the Part D plan. So there's a lot of variability in acceptance of these vaccines, partly because people get to the pharmacist, find out they have a huge copay, and they say no. So there's a lot of data on that, a lot of studies. You'll see the second bullet showing how much more likely someone is to not get a shingles vaccine if they face a steep copay. And so we're using that data to help advocate really for the fact that Part D should either put the vaccines in the lowest cost tier, that's a 0 copay or a very low copay, or add the vaccines to Part B. Still figuring out, given that Medicare will be one of the areas in healthcare reform treated next, what situation is the best option. More than anything, we just want to fix the access issue for seniors. And then, of course, quality measures, another key part of the work we're all doing. The idea is you don't get what you don't measure. How can we find a way to help all the different immunizers measure how we're doing with vaccines in adults across the lifespan? So I'll just say this is literally the maybe slide, the maybe slide, right? So we have this American Health Care Act. It's gone through multiple iterations, some of them so fast that you've barely read them and they're gone. And one of the things so far that we've seen is right now, with the versions we've seen thus far, the first dollar coverage provision does not seem to be in play. Note, I say this saying that it could change literally this afternoon, but right now, this provision is in the same area as those provisions for pre-existing conditions and up to age 26 and so on that many made campaign promises about keeping. So hopefully that stays intact. But the essential health benefits part of the bill is actually in play. There's a lot of discussions about what to do to it, and that may indeed change some people's access to the first dollar coverage for vaccines. It's unclear what undoing the EHB would do to coverage for some people. A lot of the discussion is going around the Medicaid program, and you're hearing 2 different things. You're hearing changing it to block grants, where the federal government would literally just give blocks of money to each state and they would do what they wanted with those funds for Medicaid, and or per capita caps. And this is a very interesting idea. However big your Medicaid population is, you would get so much per member per month, and you would have to pay for their Medicaid services out of that. Very managed care oriented. Unclear, again, how this would affect some of those benefits for vaccine coverage and other preventive services if they have to be folded inside of a cap. And that's one of the things that we're focusing a great deal on. We want to make sure that federal programs, particularly that buy doses for Medicaid patients, vaccines for children, 317, are not counted towards those caps. We don't want to disincentivize states because they're worried about spending that extra dollar from doing their vaccination programs. So it's important to keep the federal entitlement programs for vaccines out of those caps. And then lastly, we don't even know what the people are thinking about for Medicare, because that's actually phase 2 or phase 3 after they get done with the phase they're doing right now. So obviously, we're going to be spending our time defending those particular provisions I discussed, the first dollar coverage, trying to keep the expansions going with the first dollar coverage there, and then improving the Medicare situation, the disparity between Part D and Part B. Wow. Thank you. You are welcome. Eat.
I don't think our guests would be angry
Not at all.
but I'm sure they'd be glad to fill the.
And Laura Lee has my, if you have questions, please feel free to email me.
What an amazing job.
Yeah, that
you
was
did.
great. And thanks for sticking it out to the bitter end. We appreciate it.